when I first came to Stanford, I really wanted to do a head and neck cancer because that's what one of my mentors was at UCSF. I wear a few hats. I'm the department chair of Radiation Oncology at Stanford, so I spend a lot of time on the administration as well as mentoring the faculty members. And I also have a laboratory, and my lab works on two things. One is that one aspect is try to regenerate saliva glands because radiation wipe out a lot of saliva function in our head and neck cancer patients. So the question is, how can we restore that kind of function after we get through the treatment? The second aspect of that is we also focus on a new area of immunotherapy called the galectins, which apparently to be involved in modulating the immune system for in many solid tumor, including head and neck cancer. So we'll hope to kind of add to the current armamentarium of immunotherapy in head and neck cancers. The three ways to approach head and neck cancer: surgery, radiation, and chemotherapy. Usually, most patients who present with curable cancer, they go down to either surgery or radiation route. And the chemotherapy is adding in to help the surgery or the radiation to work better. If they're not curable, then they go down to the chemotherapy route first. So it's a very integral aspect of treating head and neck cancer. I would say that we are involved in the care of over half or maybe over to 60 or 70% of patients with head and neck cancer. Usually the patient comes and the decision is whether they go to a surgical versus a non-surgical approach, and the non-surgical approach is radiation. And it depends on the type of tumor, the location of the tumor, but certain area, the surgical treatment can be quite affecting the patient functionally, such as, if it's in the back of the voice box or the tongue, it really affects swallowing and speaking function. There are tumors that are very responsive to radiation, and in the challenging area for surgery, they should go to radiation. And so those how our triage points work very well. Anatomically from the skull base, so there's the brain sitting on top of the bone. The brain is confined within a box. It's called the skull base. So from that floor down to the clavicle, that's all head and neck. I think what we do and we take for granted, and this is I tell my patient is, you and I talk, breathe, swallow, don't even think twice about it, right? And all that function is involved in the head and neck. Especially the swallowing function. People can learn for the voice box and that new way for reconstruction, and people can talk. Swallowing will be hard, and you don't want to relegate to the point where you actually eat out the tube for the rest of your life, right? And so that's something that we really want to avoid in our cancer patient if they can do that. And in some patients, cosmetic function is very important for them. And if you ended up having, big surgery that affect part of their face or their neck, that can be psychologically traumatizing. So I think it's just a very important area to work with, and functionally it is one of the things that people rely on the most. It's also the most challenging to do because we can affect that from our treatment. So I think what we've done, the whole specialty as a whole has recognized that not all head and neck cancers are created equal, and so we've found out that there are certain type of patients who need more treatment and certain type of patients who need less treatment. And so we're smarter at selecting the treatment for our patients. With the improvement of the technology in terms of detecting tumor as well as surgical and radiation approach, I think we are curing more patients. It's not leaps and bounds. We're talking about, last 25 years, probably cure 10% more of the patient, but the side effects that we left on the patient after treatment is much less. And so these are the things that we're doing. It's incremental changes, and we'll hope to do more than incremental changes, but that's what we are right now. When patients come to you, with the diagnosis, cancer is devastating, they put their faith in you, and so you want to do the best to do that. But I think, we can do better than just what we're doing now, and not just the current patient we're taking care of, but what we can do is for future patients as well, and that's what research is all about.